Greetings to one and all. Welcome to another interesting webinar on pelvic floor dysfunction and physiotherapy by Dr. Reema Joshi. We welcome you, ma'am. Ma'am is an associate professor at D.Y. Patil College of Physiotherapy. She is a certified yoga instructor and has been awarded by Research Excellence Award in 2021 and Guru Gaurav Vidya Ratan Award by MVLA Trust Mumbai in 2021. She has more than 25 publications in various journals. It is an honor to have you, ma'am. Handing over the session to you.
That was a nice introduction. Thank you. Shall I share my screen?
Sure, ma'am.
Good afternoon, one and all. Topic of mine for today's presentation is women's health and pelvic floor dysfunction. Dr. Fareen has already given the introduction, and I'm very thankful to her for that. To go brief about my biography so far, basically, I am an associate professor, community physiotherapy department at Dr. D.Y. Patil College of Physiotherapy, Pune. I have done my master's in general and community-based rehabilitation, having certified course in yoga, and I'm currently pursuing my PhD in a women's health domain under the guidance of Dr. Manisha Rathi, madam. And I have attended scientific I have attended conferences where I presented a paper at national and international level under the under the support of our management and our institute. So without further delay, I would like to begin with. So outline of this today's session would be, I would like to give a brief about describe about pelvic floor and the functions of the pelvic floor. We will review the evaluation of the patients with pelvic floor dysfunctions. And so far, we'll try to give you the outline for the management of pelvic floor dysfunction. Pelvic floor dysfunction is you can call it involves the abnormal activity or the function of pelvic floor musculature. Now, how do we define it? The disorder that corresponds to the either increased activity or a diminished activity of the pelvic floor muscle. Technically, we call it as hypertonicity or the hypotonicity of the muscle. Corresponding to these images below, pelvic floor muscle is having a lookalike of normal hammock. Usually, according to this hammock theory, pelvic floor muscles are the floor. It gives the floor to your core muscle and helps you to maintain the abdominal pressure whenever there is a rise in the abdominal pressure. And if these muscles, now this pressure is maintained by the urethral muscles. If urethral muscles are not having adequate amount of strength, we call the pelvic floor as hypotonic muscle. And if the muscle has tone more than required, we call it as hypertonic muscle. Then we must know about pelvic floor muscles. Basically, there are three tiers: the superficial, intermediate layer, and the deep layer. Pelvic floor is the deepest layer of this three-tier system, which manages the entire pelvic floor. Levator ani, popularly called as pelvic floor, and this levator ani would be having three muscles, that is pubococcygeus, puborectalis, iliococcygeus. Levator ani wraps around the pelvis, and the coccygeus muscle is the smaller muscle which is basically giving the support and towards the back of the pelvis. The function of pelvic floor muscle primarily would be to maintain the continence of bladder as well as bowel. It gives the support to the pelvic organs. It gives the stability to the lumbopelvic system. It even controls the intra-abdominal pressure. It also helps to create a sexual function by giving the arousal and the performance action. Now, these conditions which is related to the pelvic floor dysfunctions are basically categorized into general, gynecological, colorectal, and urological. Now, what do you mean by general functions? The symptoms are reflected in the form of pelvic pain. The pelvic pain is usually the pain which begins from the umbilicus and which lasts till the lower limb. So, it involves the area around that. It can be unilateral, it can be bilateral. So the chronic pain which lasting more than the 3 to 6 months is considered as a pelvic pain. And there would be general symptom like levator spasm. Another term for the chronic pelvic pain related to the levator ana musculature, but it is labeled as levator spasm. Perineal descent is bulging of perineum below the monopelvic outlet. These are the general conditions which is seen under pelvic floor dysfunction category. Then there are gynecological conditions where dyspareunia is pain which is basically seen with or following sexual intercourse. Uterine prolapse, where is the herniation of uterus via vagina beyond the introitus. This is what is seen. Vaginal prolapse is a herniation of vaginal apex beyond the introitus. Enterocele is a bulging or a herniation of intestine into the vagina, apical or posterior. Rectocele is a bulging or a herniation of rectum into the vagina. These are the gynecological category of pelvic floor dysfunction. Colorectal, which is very common, moreover, on the western part of the world, but constipation, paradoxical contraction, or the inadequate relaxation of pelvic floor musculature during attempted defecation. It could be because of the dietary patterns, fecal incontinence, involuntary leakage of a stool, rectal prolapse, where there is this interception of the rectum beyond the anal verge, commonly called as precedentia or proximal to the anus. Urological complication is commonly seen as difficulty in urination, which involves hesitancy, delay in urinary system. There would be cystocele, there is a bulging or a herniation of a bladder into the vagina, especially anteriorly, anterior towards anterior vaginal wall. Urethrocoele, there is a urethral prolapse, bulging of urethra into the vagina. Urinary incontinence is basically called as involuntary leakage of urine. This is the urological category of pelvic floor dysfunction. Then there is a need, the common symptom which has been seen as a pelvic floor dysfunction among Indian category or so far in a more amount of prevalence is the urinary incontinence. So pelvic floor dysfunction has a many other factor, many other arenas, and one of the area is urinary incontinence, which is very common, and hence I would like to highlight my presentation towards this condition. Now, urinary incontinence is one of the involuntary loss of urine that is social and hygienic problem, and it is objectively demonstrable. This definition is by International Urogynecological Association and International Continence Society. Urinary incontinence has its sub classification in the form of stress urinary incontinence, urge urinary incontinence, mixed urinary incontinence, as well as other incontinence, which includes postural incontinence, functional incontinence, and there are reasons and there is a description according to the classified category. Now, stress urinary incontinence is basically involuntary loss of urine on effort or a physical exertion during coughing, sneezing, or lifting heavy weight. Basically, whenever there is an increased amount of abdominal pressure, there would be physical exertion, and that would be reflected in the form of urinary leakage. Now, what is the cause of having stress urinary incontinence? That would be trauma which occurs during childbirth, and as the number of parity would be increased, the chances of having stress urinary incontinence would also be high. Repeated urogynecological surgeries are the common reason. Neurological diseases including other multiple sclerosis, DMD, these conditions are commonly seen to have stress urinary incontinence. As the individual will age, may it be male or may it be female, stress urinary incontinence is the risk one would have. Particularly in case of female, postmenopausal females have seen with stress urinary incontinence due to the decrease in the amount of estrogen reuptake. Second classified category is urge incontinence. Now, this involuntary loss of a urine associated with the urgency. There are three main etiologies intrinsic to the bladder that leads to urgency incontinence: detrusor overactivity or the poor detrusor compliance and the bladder hypersensitivity. Actually, to maintain the continence, the micturition reflex has to augment on the time. Micturition is a process which needs to be understood before that, how it helps to maintain the continence. Because as the bladder, if bladder is having its normal capacity to accumulate the urine, till then detrusor need to remain, they are basically supposed to allow the stretch and get distended until the bladder would get filled. Once the bladder is filled to the level of basically bladder has a capacity up till 500 ml, right? But bladder has to give the sensory input so that one gets prepared for the process in case there is a or some sort of emergency to void. So at a 250 to 300 ml, bladder would give the sensory input to the brain, and then brain would make the necessary, give the necessary output, and the likewise the arrangements would be done. But in case of bladder filling phase, when bladder is filling, at the time if detrusor would go for contraction, then it would cause the urethral muscle or the intrinsic sphincters to relax, and that is cause the urge incontinence. So this mechanism get breaks. The continence mechanism would get break, and hence the urge incontinence would take place. Usually the system is bladder has to get completely filled. Once the bladder is completely filled, then only this bladder would give the sensory input to the brain, and that's how the process of micturition takes place. But if it gives the sensation of filling during the filling time itself, then there would be no control over the bladder, and then one has to rush, and this is what called as the urge incontinence. Then there is a category that is mixed urinary incontinence, where is a complaint of involuntary loss of a urine associated with urgency and also with the effort of physical exertion. So this basically is seen to have the both the symptoms of stress as well as urge urinary incontinence. We need to, at the time of assessment, we need to identify the category, the grade or the severity of stress urinary incontinence as well. So according to the Engelman and Sundberg in 1995, they have given the grades, 3 grades of stress urinary incontinence. So one can decide a treatment appropriately. So that is my uh, my aim to put these grades over here so that one can decide the severity and your physical therapy management according to that severity. Grade 1 would be incontinence with only severe stress such as while doing a coughing, sneezing or a jogging. Grade 2 would be the incontinence with moderate stress such as fast walk or going up and down stairs. Grade 3 incontinence with mild stress such as walking. So you can categorize the stress urinary incontinence likewise, and you can decide a treatment according to that. Now, whenever you assess an individual who has the urinary leakage symptom, the common problem while when we assess the people with pelvic floor dysfunction, when particularly looking for a patient with urinary incontinence, there is no one set of definition which people are asking to the people. And that's why people are not getting educated towards the problem. Hence, we have to educate the people that they need to report even if this problem. Usually the concept among people is that they are they are not related. They think it is a normal process of aging, that one is not able to control the urine. Since I'm a older individual, I will have some sort of this dysfunction, and that's why people are not able to report this problem in first hand. And as a professional also, we are not able to ask question because we don't have the set of um, document which we can use at the time of assessment. So there is a lot of material available in terms of assessment of urinary incontinence. One need to actually ask the question to categorize the severity, then exactly which type of question should be asked to diagnose the people with stress urinary incontinence and to know about the urge urinary incontinence. When we say somebody is having stress urinary incontinence, when we need to ask the question related to the stress. Now, this stress has to be specifically towards intra-abdominal pressure that would lead to the stress to the pelvic floor, especially towards the urethral mechanism, towards the urethral pressure here means to be. Now, this urethral pressure, we need to know how much it should be. Even if some people come with the assessment in terms of uroflowmetry, we need to know the report. We need to understand the report or the manometry findings for that patient. So the question in our history should lead with what is reported by the woman, how she is presenting her problem. Is she reporting about symptom? How she is narrating her symptom. Her symptom is either she would report to you that I find it that I may leak a urine whenever I sneeze or cough or lift or do something. She may not say that I have a urge or I may have a stress only. She would be reporting sometimes to you that I find it difficult to hold the urine for a longer period of time. Sometimes one has to ask the leading question to the patient. So, what type of symptom clinician would observe? That has to be known. That has to be understood. The classical test one should know. The cough stress test is very much popular among gynecologists, among urologists. They usually ask that female to demonstrate the cough stress test. Q-tip test is very much popular. And it is also on the basis of urodynamic studies. For example, uroflowmetry. Uroflowmetry is quite common. It is a specialized test which helps to determine the amount of uh, urinary leakage or it is basically helpful to determine the sensory or the motor cause of urinary incontinence. Understood? Now, how do we assess people? How do we examine the people? The people basically, once they report to you about urinary incontinence, or you end up saying that this person needs to be evaluated. Now, this person has to be evaluated considering the pelvic floor dysfunctions. The nature of dysfunction is hypertonic pelvic floor muscle or a hypotonic pelvic floor muscle. To know whether the person is having hypertonic muscle or a hypotonic muscle, physical examination and before that history of patient's symptom is very much important for us to know. Visual inspection of the pelvic floor muscle has to be taken place, including the bulging with the pelvic organ prolapse. If at all it is noticed, that has to be reported in your assessment. Pelvic floor contraction has to be seen, which basically should leave the perineum, right? And cotton swab test is basically for localizing the vulvodynia. If at all there is a person who is having hypertonic pelvic floor muscle, one needs to know the sensitivity, and cotton swab test would be able to determine that. Speculum exam for the atrophy or the inflammation of vaginal mucosa is commonly done by the gynecologist to know if at all there is any inflammation. And that's how one can identify whether there is a acute symptom of inflammation present and if at all there is a need of medication at this point or a physical therapy, right? Digital palpation of pelvic floor muscle for the contraction and the relaxation has to be attempted by the patient themselves, and this assessment has to be done. If patient reports pain, that has to be recorded. Palpation of urogenital triangle, which includes the ischio-cavernous bulbospongiosus and the transverse perineal muscle and the perineal body, is especially important in assessing dyspareunia. because some of the young female usually report to the gynecologist, and at times in when you go for a detailed assessment, you would come to know that people would report to you that she finds it difficult. She finds that whenever she would attempt for the intercourse, there would be painful. That would be painful. It also causes the patient very uncomfortable sensation, right? Rectal digital exam is to be performed to evaluate the sphincter tone and the pelvic floor muscle, especially the coccyx, which exclude neoplasm, to identify sources of pain, hemorrhoids, if at all, anal fissure or anorectal abscesses. So this detailed assessment help us to determine whether or how much pelvic floor assessment would be allowed by the patient themselves. If patient is having this problem related to hemorrhoids, anal fissure, then definitely the symptom of the patient would be different. Anal sensation has to be evaluated. The response to the touch and a pinprick has to be recorded. Now, in regard to the pelvic floor dysfunction, one has to understand that why we should know about pelvic floor dysfunction. Why it is important to maintain, to assess pelvic floor dysfunction. Basically, pelvic health is the most important part for the female in terms of reproductive health, right? And it is assumed that all these pelvic health symptoms would begin once the patient would reach to the menopausal age. Whereas the data presented by International Continence Societies clearly mentioned that female above 35 years of her age has been seen with one or other symptom of pelvic floor dysfunction. And the reason for that has been a childbirth or the trauma during the childbirth, number of children, how much ever she has delivered. If at all there is a overweight female, if she has any sort of addiction related to caffeine intake or may be smoking for that matter, she has been seen with one or other symptom of pelvic floor dysfunction. Hence, pelvic health, one has to understand. So, pelvic health is basically a study of a female anatomy, pelvic organs, and their function along with the muscles supporting pelvic organs. Now, this is throughout her life. She's handling the pelvic health, right? So, it need not to be focused towards her early age, middle age, or the old age. It has to be focused towards all the years of her reproductive age. Pelvic health regulates various incidences in females' life, like menarche, pregnancy, childbirth, sexual activity, and pelvic floor function. So, throughout her lifespan, pelvic floor muscles are affected directly or indirectly with one or other risk factor. What would be your advice? What would be the treatment to begin with? Now, one has to understand the pelvic floor muscles. If at all there is a hypertonicity of the muscle is identified. The common cause of hypertonicity of the muscle is basically person's apprehensiveness has been seen. There is a lifestyle of the individual is also responsible to cause the hypertonicity of the muscle. There is no timed voiding. People delay the voiding. If even after having a strong urge to void the urine, still there is a nature or maybe there is an unavailability of the proper urinary lavatories or maybe the toilets which is unavailable, and in that case unfortunately that female has to hold back the urination, and that is also one of the reason of hypertonicity of the pelvic floor muscle. So the treatment for the hypertonicity of the muscle would begin initially with the assessment. If at all there is a hypertonicity, you would see the female would have a dyspareunia symptom more. And vaginismus is also one of the symptoms which come across among the female with hypertonic pelvic floor muscle. In this case, there is a lot of need for lifestyle changes and the healthy habits. So that is the reason the pelvic floor or a pelvic health depends on the holistic approach. So the diet and nutrition has to be appropriately consumed. It has been also seen that female due to unavailability of toilets around them, they tend to consume less amount of liquid food, and that's why they end up delaying their urination. Now, this is seen among older people, especially the diabetic females. They have a most amount of post-voidal urine retention. The reason of incomplete emptying of the urine, as well as delaying the voiding, as well as not targeting their own selves first. Delaying due to any other reason, may it be if she is occupied with some if she is occupied with some work, if she is looking taking care of her children, if she is traveling, if she is at office, if she is in a meeting, the nature is that she would delay, and that would lead to infection at the same time. So diet and nutrition is one of the lifestyle change one has to adopt, and this knowledge will help you to avoid the foods or the kind of food what you are consuming. If you are consuming the food which is high in sodium, as well as the spices is high in that food, definitely the person would have the uh, increased amount of urinary urge incontinence. Especially the drinks which is rich in caffeine, that may irritate the bladder, because that would uh, give the stimulus to the detrusor muscle, and they would respond, or they would contract before the time. And the second lifestyle change would be changing any behavior that make your symptom worse. As one, if at all one has to understand that what would trigger my symptom, they need to analyze their lifestyle for that matter. If one understand that my lifestyle includes something, some diet, some activity, some physical exertion that exacerbate my symptoms, that has to be minimized. Techniques to decrease urge and the frequency has to be adapted, such as improving the muscle strength and the stretching. Because we have seen the overweight individual are seen with more amount of urinary incontinence symptoms. Setting and keeping a healthy bathroom schedule is should be the habit, should be a routine. One has to reach to the waist to achieve a regular bowel movement. Constipation or a large amount of stool in a bowel can cause the bladder to not empty well. And these also can place pressure around the bladder and increases the urge to urinate. The importance of drinking healthy fluid has to be developed on a regular basis. There are safe ways to achieve regular exercise or develop more active lifestyle in terms of doing regular exercise, regular yogasana. Meditation has, along with the breathing exercise, have shown with a good result towards hypertonic pelvic floor muscles, because that would introduce the relaxation where the muscle has not having ability to relax in a complete way. So the main principle of therapeutic modalities used in the physiotherapy for stress urinary incontinence, we can summarize it like pelvic floor muscle exercise requires a lot of awareness. Awareness towards the pelvic health professional, that how they are going to assess this muscle, as well as teach the patient to locate their own muscle. Pelvic floor muscle is assessed and exercised in a functional position. As in, pelvic floor muscle is already an anti-gravity muscle. If it is going for the weakness, one has to begin from the basic. As in, patient must be lying on the planes or the bed, and one has to assess the pelvic floor first. If the muscle is hypotonic, exercise has to be started off. Once you know the strength of the muscle, once you know the power of the muscle, once you know the contraction produced by the person, that has to be evaluated. And to assess that, subjective and the objective method of assessment has to be adopted. Subjective method of assessment gives the confidence to the patient how much amount of contraction would be enough to produce a reading. Objective method of assessment, pereniometry, is one of the assessment tool which is very much easily available, portable, and helps a patient also to give the feedback against the vaginal probe which is supposed to be inserted, and that's how one can able to contract against that, and pelvic floor muscle strength can be determined. At the same time, the pelvic floor muscle is having the function to maintain the continence. In this same case, the severity of incontinence also need to be assessed. Severity of the incontinence can be assessed with the help of assessment tools such as PAT test. Now, this PAT test is very much easily available. Sanitary napkin has to be procured and patient has to be given. Before that, the pre-weight of the sanitary napkin has to be measured, and after giving it to the patient, 1000 ml of water has to be consumed by the patient, and the regular activity has to be followed. In that 1 hour, basically PAT test can be performed for 1 hour and the 24-hour as well. 24-hour activity, definitely one may not able to have a accurate reading, because for that lot of observation is supposed to be done. So 1 hour pad test is quite common and popular among professional, which gives the reading within an hour. And once you allow the patient to go up with the activities, the patient is supposed to walk, climb stair, do the regular thing, and then sit back, right? And then again after 1 hour, sanitary weight, sanitary pads weight has to be done. And if at all there is a difference between the pre and the post weight, then only we can say the severity of incontinence is there, right? So this 2 to 3 assessment is mandatory towards incontinence, especially if it is of stress urinary incontinence origin, right? The first foremost important question is asked by the patient that I am having this problem and this is very severe in my case. What exactly should I do? In that case, popular maneuver which we have to teach to the patient, that is NAC maneuver, given by NAC principle. Now, what is this? Whenever person is trying to cough or a sneeze, at the same time, that person is supposed to contract the pelvic floor muscle and then only would go for sneeze or a cough. Apart from that, if still person finds it difficult to hold a urine, then definitely adductor contraction by crossing the legs and then contracting the pelvic floor muscle has to be taught. This is an immediate mechanism one can really adapt to hold any unwanted urinary leakage at inappropriate place. Along with this, once you determine the hypertonic and the hypotonic pelvic floor muscle, in case of hypertonia, we have seen vaginismus or the inappropriate contraction of pelvic floor is seen, and that would be the one of the reason of dyspareunia as well. So once you determine the muscles are hypertonic, in that case, the approach has to be different. Pelvic floor exercises or the strengthening would not be our priority in case of hypertonic muscles. Whereas one has to adopt the strategy which helps to minimize the hypertonic muscle. The tone of the muscle has to be minimized. In this case, breathing exercises, meditation has to be incorporated in their protocol. Once the tone of the muscle is adequate, normal, then pelvic floor muscle exercise can be given as a protocol. Now, most of the female, those who have experienced pelvic floor dysfunction, are usually, if they are having childbirth injury or may be due to high amount of parity ratio also, hypotonia is the most common problem in pelvic floor muscle, which leads to pelvic floor dysfunction ultimately. In this case, pelvic floor exercises, graded exercise has to be included. Now, the pelvic floor exercise, you have to begin with the patient initially, making that patient lie in the supine position, side lying position, prone position, quadruped position, and progressing with the standing position. That's why pelvic floor muscle exercise can be graded according to the patient's position. But the muscles are rich with the slow twitch fiber. 70% slow twitch fibers are present in this muscle. Hence, we have to begin with the endurance specific exercises where the number of contraction has to be more, right? So the endurance specific exercise has to be given more. To progress it further, there one can also use vaginal cones and vaginal weights, which can further strengthen up the muscle and give the feedback to the patient as well. Now, the pelvic floor muscle exercises are performed until the muscle would get fatigue, or before that. Several times a day it can be practiced. Initially, you can practice from 12 to 20 weeks, but this is the only form of exercise if it is given in the preventive form, or if it is given as an treatment form, or if it is given as a maintenance form. It has been seen with the um, effective mechanism is very great. Now, this pelvic floor muscle exercises has to be continued. The problem here begins that there is a very less literature available in Indian context towards urinary incontinence. The literature is always, whatever is observed in the databases is coming from the western part, especially in terms of physiotherapy evidences. We still are not able to find out the records of female who are suffering with this problem. Hence, the guideline given by the NICE, that is National Center of Investigation Excellence, NICE guidelines have forwarded the pharmacological and non-pharmacological approach towards urinary incontinence. And non-pharmacological approach includes the holistic attitude in terms of what kind of food you are eating, how much amount of fluid you are taking, what type of fluid you are consuming, if you have any addiction, if you have any attitude towards exercise, what kind of exercise are you doing? Are you supposed to have this exercise? Are you losing weight or gaining weight frequently? Because even if person would look would change the appearance in terms of weight gain and weight loss, I mean to say, we are not giving enough weightage to the pelvic floor muscles. And in this um, weight gain and weight journey, pelvic floor muscle suffers at the same time. Hence, the exercises are supposed to be given considering pelvic health as well. So when you say a core muscle exercises are helpful, core muscle has to be determined first. When you talk about core muscle, core of what? Core muscles are basically the abdominal muscles, basically the back muscle, basically the floor. So we consider core as a cylinder. So abdominal muscle, if at all we consider as a cylinder, so there has to be a lid, there has to be a floor, there has to be a boundaries. So if lid has been managed by the diaphragm, so respiratory capacity has to be adequate enough to manage the intra-abdominal pressure. So the diaphragm, in a way, indirectly, also needs to be strengthened up in regard to pelvic floor rehabilitation. Core muscle means abdominal muscles, where the rectus abdominis and more than that, transversus abdominis has to be focused to maintain the lower abdominal strength. Hip muscle focusing at the gluteal muscle has to be strengthened up. Multifidus is the deepest back extensor muscle has to be strengthened up. And then the pelvic floor of this core muscle is the pelvic floor. This has to be work in the harmony to give a good pelvic health. And the report has to be every kind of a female who is coming to you with a pelvic pain or the pelvic related issue definitely should be inquired about symptoms related to incontinence, symptom related to urinary muscles, symptom related to other kind of muscles. Because reproductive health is not only supposed to be focusing at antenatal period, it also requires lot of gynecological concerns of the female during different stages of their life. That is the reason the quote I would like to give here is, communities and the countries and ultimately the world are only as strong as the health of their women. Michelle Obama has given this quote, and it very well mentions that the health of the woman should be prioritized then only family health would be fine to be optimally present in the status. So here I would like to conclude my talk, and thank you for listening.
Thank you so much, ma'am. I have a few queries, ma'am, if that's fine.
Yeah, sure.
Ma'am, you talked about the core being a complete capsule or a tin. So whenever we are looking at pelvic floor muscle, from where should we start? From the diaphragm, from the abdominal or the back core muscles, or the pelvic floor?
Now again, if this question is asked by the postnatal female, if this question would be asked by the menopausal female, if this question would be asked by the old age female, our concern would immediately change as per the condition or as per the age of this individual, right? So if you are asking me on behalf of some postnatal female, I would begin with the pelvic floor muscle directly. If you would be targeting as a preventive mechanism, I'll begin with everything slowly at a stretch. But I would like to begin with the core muscles along with the pelvic floor muscle. But I will also give a weightage if at all she is having any respiratory complaint, because that is going to cause the pressure, that is going to create the problem with the urethral mechanism, because transmission theory clearly mentions that pressure would get transmitted to the urethral sphincters, and thus we need a holistic approach while managing this entire female.
Right, ma'am. Another query that I thought of was you talked about meditation and relaxation before properly contracting. Does this have any relevance with the reverse Kegels that are coming up recently, ma'am?
Yes, it do have, because uh, when we talk about meditation and the breathing exercises, definitely these days the lifestyle of a woman, she herself is only aware about. So
Mhm.
that is the reason we should always inquire that how was her day. We need to change as a guy, physiotherapist. We need to change our attitude to ask the problem. We end up concluding the patient with a musculoskeletal impairment straight away and want to treat that patient with a with the immediate care. But here I would like to know her history, her day-to-day routine, her problem, and I would like to assess her with the utmost priority, at the utmost attention towards her only after her consent. And unless and until I find the pelvic floor muscle are having hypertonia or the hypotonia, I will not at all going to conclude my treatment towards breathing exercise, towards meditation.
Mm-hmm.
It is going to be helpful. But if I want to begin with it, I need to know the cause. If the muscle are hypertonic, it has been seen that female delay the urinary frequency,
Right.
delay, delay the urination process, and that has been seen to be the reason. This is very simple reason, but that overall, if it get accumulated, it creates a lot of problem in future. Right from the young age, it has been seen.
Right.
So I would like to incorporate. Definitely, it has its own perks. Yoga is all over popular. Yoga has shown its effect. We need to create a database. Unfortunately, we don't have a lot of evidences in India about our own yoga and the breathing exercises upon all possible um, problems, whatever we have.
True, ma'am. That's right.
Yes.
Thank you so much, ma'am. It was indeed an engrossing webinar. I take this opportunity to thank Dr. Parag Sancheti and Manisha Sangvi ma'am for providing us with this amazing platform. I would also like to extend my thanks to Dr. Apurva Shimpi, our principal, for giving us the opportunity, and of course, the PhysioTV technical team for their continuous support. And lastly, I would like to thank our dear viewers for continuous support. Thank you so much, ma'am. It was really good to have you over Physio TV.
Yeah. Thank you, Dr. Farin, for uh, being so nice companion throughout this webinar. I would like to extend my sincere thanks to Sancheti Institute of Physiotherapy for providing me this opportunity. And I need to thank Dr. Apurva Shimpi sir for being a constant source throughout this series of webinar. I would also like to thank my friend and my uh, your colleague, I would say, Dr. Radha Bhattad, for providing me this opportunity, and definitely would like to look forward. And you're doing a great job. Thank you.
Thank you so much, ma'am.
Thank you.